Class, we left off last time with chapter 21, and now we're going to go into chapter 22, patients with head injuries or spinal cord injuries. And when I stopped on chapter 21, we were talking about neurochecks. I'm going to bring that up again in this chapter. So not to worry, I did not forget to talk to you about neurochecks. So let's talk about head injuries first of all. And we'll mention concussions. Some of you may have had a concussion in your life dealing with playing sports, that sort of thing at school. But head injuries account for 52,000 cases per year in the United States of head injuries. That's a lot of head injuries. So when we look at, first off, let's talk about the aging brain. After someone turns about 70 years old, their brain actually shrinks a little bit. So if they do fall, and that's one of the number one reasons for a head injury is a fall. If they do fall, they have, the brain is smaller, so it's got more room to move around and do some injuries to vessels when someone falls. So there's more venous damage during a fall as someone ages. As far as signs and symptoms of a fall, there can be bruising, there can be swelling. You've got a couple of good pictures in your book about battle sign, which is bruising behind the ear. Someone can also have bruising around the eyes, called raccoon eyes. And you actually have these occipital bones on the face, which really do help protect your skull, help protect your eyes. But raccoon eyes is when you have swelling around the eyes. You can also have a patient who has some fluid draining from the nose, the ears, possibly. That could be a sign also, or something that happens during a head injury. And to diagnose that there has truly been some damage, a CT scan could be done or an MRI with contrast. So let's look at some different types of head injuries. You've got some really good pictures at the bottom of page 501. So if you'll turn in your chapter 22 to page 501 and look at the pictures near the bottom of the page there with your coop, contra coop injuries, subdural hematoma, epidural hematoma, intracerebral hematoma, and be familiar with those. But if we're talking about an open head injury versus a closed head injury, an open head injury, there is a laceration to the scalp, a fracture of the skull, and with a closed head injury, there's an underlying tissue damage, and increased intracranial pressure can result from that. We're going to mention increased intracranial pressure quite a bit during this chapter. Normal intracranial pressure is 0 to 15 millimeters of mercury. You can write that as ICP 0 to 15 millimeters Hg. 15 lowercase mm, capital H, lowercase g. Normal intracranial pressure is 0 to 15 millimeters of mercury. A contusion is when the brain tissue is bruised, and a coop contra coop injury, think of an acceleration and then deceleration. So someone's driving in a car and they are hit from behind, their head hits the front windshield and then snaps back and possibly hits something else, or even the brain hitting the back of their own skull can cause this coop contra coop injury. And there's a picture of that in your book. Also, subdural hematoma is where there's going to be a blood-filled area. And when you look at the picture at the bottom of page 501, you see the subdural hematoma is underneath the dura in picture A there, the space under the dura mater. And in B, you have an epidural hematoma where an artery is torn and it is above the dura. The subdural hematoma and the epidural hematoma can both be fatal. Epidural hematoma is an emergency situation needing immediate craniotomy for relieving the pressure. Increased intracranial pressure, page 501 pictures. Okay, I showed you that. Now let's, when we talk about concussion, if you're working in a doctor's office, pediatrician's office, mom calls in to talk to you because their toddler has fallen and hit their head on something, or they've fallen off of a height, possibly fallen off a play tower playing. Son has gotten hit in the head with a soccer ball while playing soccer, something like that. If there's a brief period of loss of consciousness, brief period of amnesia, and a headache associated with that, that's usually a concussion. They do need to come in and get checked for that. They can still have testing, CT or MRI to get checked for that. And we have a really good section at the top of page 506. It talks about instructions for care of a patient with a head injury. I would like for you to look over that. You've got information there to teach the family about watching for complications having to do with that, watching for a decreased level of consciousness, headache, vomiting, change in vision, change in what the eyes look like, and things like that. So be sure and read through that at the top of page 506, instructions for care of a patient with a head injury. As far as surgical intervention for a head injury, before the surgery, someone is, if they haven't had a major injury and are able to do this, getting the head as clean as possible for surgery, or the nurse being responsible for that, if there's time to do that. After the patient is under anesthesia, the area where the surgery is done will be shaved. The patient will go to the ICU for management after the surgery. They need to be monitored for close watch on vital signs and some other things that we'll talk about. They need to be in a quiet environment, have the head of the bed elevated 20 to 30 degrees, or whatever the surgeon has written in the orders. It's very important about positioning the patient after brain surgery or even after head injury to monitor and make sure the patient doesn't have an increase in intracranial pressure. So if the patient is moving around too much, even if they grab the sides of the bed and push themselves up, push with their feet against the foot of the bed, bend their knees up in the bed, all of those kinds of things can cause an increase in intracranial pressure. And our goal in surgical intervention, or even caring for this patient that has had a head injury, is to keep the intracranial pressure normal. After a head injury, your book talks about there's an unpredictable recovery. We talked about sometimes the brain cells, some brain cells can take over for other brain cells that have died. And I myself, over the years, have seen many people who've had head injuries, not necessarily in my work as a nurse, but people I've known, unfortunately, have had great recovery with head injuries. And I've also seen cases where the situation has gone very poorly. There was a child that was injured in the Chattanooga tornado just days ago. I think he's 3 years old with a head injury. Unfortunately, he passed away. So unpredictable, and there can be some very sad cases of this. But okay, post-operative care. We talked about positioning being very important. You want to keep the neck in midline and prevent excessive hip flexion, because that can cause increasing intracranial pressure. Use caution when performing any suctioning. In fact, if it's not in the order, don't do it. We don't want this person to blow their nose, sneeze, cough if possible. Watch for cerebrospinal fluid leakage from nose, ears, operative site. As I said, a quiet, non-stimulating environment, and prompt reporting or calling the physician if you have any reason to suspect the patient is going downhill or increased intracranial pressure. If the patient does have any leaking of fluid from any orifice and you're not sure about what that is or not sure what you're supposed to do, call the physician about it. On the top of page 502, you got a picture of a gauze pad and it shows a blood circle in the middle with a lighter circle around it, so, and that's called a halo sign. Blood in the center is usually a sign where the blood will move towards the center of the secretion, is a sign that it is cerebrospinal fluid. Also, a dextrose stick can be done. If it's positive for glucose, that is a sign that it's cerebrospinal fluid also. Patient is going to need to be postoperatively on absolute bed rest. If there is a draining orifice, cover it with a sterile gauze. Avoid picking at the nose area, blowing the nose. Do not block any drainage. Also monitoring the patient for seizure. And we also want to monitor the patient and not sure that we are fluid overloading them. So as far as an IV, usually it's not going to be over about 50 cc's per hour. And in talking about increased intracranial pressure, anytime there is swelling within the cranium, whether it's from an injury, infection, a tumor, growth, something like that, it can be a cause for intracranial pressure to increase because it's taking up space within the cavity. So that's what causes this increased ICP, or increased intracranial pressure. Also, pressure could progress and cause pressure on the brainstem. This can cause a change in vital signs and pupil reaction or changes in the pupils. Remember in our last chapter, we talked about that is one of the #1 reasons you need to get your surgeon on the phone if you see any changes to the pupils. We talked about assessing them when you first assess your patient. So if you see changes, also looking for vital sign changes, respiratory changes that we'll talk about in just a second. As far as increased intracranial pressure, we're not going to be tested on meds during this section, but they can be given osmotic diuretics, Lasix, Decadron, possibly be on ventilator if needed, oxygenation, can be given barbiturates and anti-seizure medications, and temperature control because of the swelling that has infected the midbrain or brainstem. Careful neurological assessment needs to be done on these patients at the beginning of your shift, and neurochecks could be ordered on the patient. Well, they'll definitely be ordered on the patient, but depending on what the surgeon wants to do or the managing care physician wants to do, they may be ordered every 15 minutes possibly, or every 2 hours if your patient is acute. Now, as far as a neurocheck, what you're talking about with a neurocheck is measuring the level of consciousness. If your facility uses the Glasgow Coma Scale, that might be what you could use, or the 4 scale for level of consciousness. Also, pupillary reactions. So you're going to do your PERLA, see what the pupils look like. Are they equal, round, reactive to light? What's going on with the pupils? Charting that. Also, level of neuromuscular activity. It may be poor on your patient first off, but checking hand grip on your patients if possible. Like we talked about, can they push against the force with force? Also vital signs. So let's look at increasing intracranial pressure and what's going to happen with the vital signs. Yesterday we talked about a widening pulse pressure. We talked about if you checked your patient's vital signs and let's say you get 124 over 84, and then the next time it's 132 over 72. So that would be an instance where there is a widening pulse pressure. That could tell you that intracranial pressure is increasing. Extreme restlessness or excitability following a period of calm, that could be a sign. Deepening stupor, decreasing level of consciousness. Headache that is unrelenting and increasing in intensity. Vomiting, especially persistent or projectile vomiting. Your book calls a Cushing's triad on page 506 as increased systolic blood pressure, widening pulse pressure, and bradycardia as classic sign of increased intracranial pressure. And that is on page 506 at the bottom. So be sure and read through that. Bradycardia, I think I mentioned that already, but bradycardia is a sign, and actually rapid respirations. As the body tries to compensate for what's going on, then you'll see the patient possibly have irregular or rapid respirations. If you had an ophthalmoscope and knew how to do it, swelling on the optic disc is also a sign of increased intracranial pressure. Unequal size of pupils, abnormal pupillary reactions, leaking cerebrospinal fluid from the nose or ear, changes in blood pressure, respirations, slow bounding pulse. So not only will they have bradycardia, but it might be a bounding pulse also. So goals of nursing care. We want to maintain the cerebral perfusion. We want to reduce intracranial pressure with medications, possibly the use of barbiturates, maintain adequate respirations, protect from injury, maintain normal body functions. For example, if the patient had damage to the brainstem from the swelling, then they may have a high temperature, so cooling blanket might be used. We want to prevent complications of seizure, DVT, because of the immobility, blood pooling in the extremities. Also, the swelling in the brain can cause pressure on the pituitary, so you can see some really high blood sugars. So you might want to monitor blood sugar on this patient. So monitoring respirations, monitoring vital signs, monitoring blood sugar, safety measures, monitoring for seizure, monitoring for any signs that we just talked about for increased intracranial pressure. And if it's not contraindicated, more than likely it would not be, because most of the time after a surgery, brain surgery, or head injury, as long as there's not a spinal injury, can keep the head of the bed elevated 20 to 30 degrees. But remember, we want to keep the head in the midline. Your book has a section that talks about using a catheter to measure cerebral perfusion pressure, and I won't be testing you on that. That's more of an ICU procedure, specialized procedure, but you can read through that section, but you won't be tested on that. All right, let's move on to injuries of the spine and spinal cord. Injuries of the spine and spinal cord begins on page 509. There are 12,000 spinal cord injuries in the U.S. per year. And you would imagine those more frequently as head injuries too at the beginning of summer. I watched a few videos about people who have had head injuries and spinal cord injuries, and many times it started out, I was going on a trip to blank, and we were going to do parasailing or something like that, or diving, and an injury happened. So they're on YouTube. You can find them as well. I can tell you a couple of great stories to read through if you would like to hear stories of people who have survived head injuries or spinal cord injuries. There's some really good ones to read through. And it helps you understand the process of how they feel when this happens, the grief that they experience when this happens, the loss of function, pain associated with it. So some really good stories to read. Remember, nerve cells don't heal. So there's a loss of function below the level of injury with a spinal cord injury. It's diagnosed with a CT or MRI, but certainly diving accidents, falls, some type of extreme sports, or even a motor vehicle accident can cause a spinal cord injury. Above the C5 vertebrae is usually going to be a fatal injury. There were some stories I found when I was looking of people that had survived above the C5 injury. but your center for controlling respirations is above the C5 area and the nerves that control respiration, so they would have to have very quick emergency help to be able to survive that. With a lumbar vertebrae 1 or 2, usually they're going to have paralysis in both of the legs. And if there's an incomplete severance of the cord, they can have a temporary paralysis from swelling. So with a complete severing of the cord, they're going to have loss of function. With incomplete, they can have some swelling for a few weeks that they could recover from, possibly. You have a chart on page 512 that talks about the level of spinal cord damage, 512. And if you look through that, just like I said, you can see that C1 through C3 says no respiratory function, usually fatal. And then if you move on down to C6, you see that they can retain gross motor function of the arms, partial shoulder, elbow, and wrist movement, but they're still listed as a quadriplegic. And there's activities that are possible listed with each spinal cord injury there, and some thoracic injuries are listed there. And note with T, thoracic vertebrae number 11 and below, they have a loss of bowel, bladder, and sexual function. All right, when we're talking about spinal cord injuries, 4 main objectives: saving the victim's life, number 1, preventing further injury to the spinal cord by carefully handling the patient. So you've been taught when you took first aid, CPR, not to move the patient if you think they have a spinal cord injury. Of course, you are going to have to make sure they're breathing, but preventing further damage by moving them as little as possible is very important. Repair as much of the damage to the spinal cord as possible. And when they are assessed, they can be given steroids to prevent swelling that's going to occur that can hopefully help prevent some of the damage that's going to be caused. Establish a routine of care as far as your 4 main objectives. Establish a routine of care that will improve and maintain the patient's state of health and prevent complications so that eventual physical, mental, and social rehabilitation is possible. So treatment and nursing management. Just like I said, respiratory management is most important at first. Then immobilization and surgery if indicated, urinary management, psychological care, grief and mourning response, and sexual concerns. There's a lot of complications to spinal cord injuries. Spinal shock can be immediate. It can last 48 hours to weeks. And also neurogenic shock, that can be because of a loss of vasomotor tone. These are on page 514. Can cause bradycardia, decreased blood pressure, and that is why it can be such a dangerous situation, neurogenic shock, because of the great drop in blood pressure. They can be given medications, but the goal is to maintain the blood pressure. It's usually associated, as your book says, with a cervical injury or a high thoracic injury as far as neurogenic shock. Muscle spasms. Your spinal cord injury patient can have a great deal of muscle spasms and voluntary contractions that are really, really strong. Your book talks about they can even fall out of the bed, and to try to avoid grasping a muscle if you're helping move a patient to keep this from happening. Also read through autonomic dysreflexia. This is a sudden severe hypertension on page 516 that can happen to your patient, and it's associated with full bladder, constipation, tight clothing around the waist. And so if you start seeing sweating in your patient, possibly signs of sudden hypertension, this could be what's going on. Orthostatic hypertension can happen because of pooling of blood in the extremities, Also, deep vein thrombosis or DVT can happen because of that pooling of the blood. Infection, skin breakdown. They're immobile in the beginning, very immobile, so of course they can be prone to skin breakdown. You've got a good picture in your book of that. Roto-Rest Delta Advanced Kinetic Therapy System to help with moving the patient, and that certainly will help with skin breakdown, but something to watch out for. Infection, also they can have urinary reflux and frequent catheterizations, possibly, lots of reasons with the skin too for infections. Heterooptic ossification can be from immobility also, and a bony overgrowth that occurs. With your patient with a spinal cord injury, watching out for oxygenation, vital signs, skin damage, making sure they are passing urine, passing stool because of the immobility, watching out for their nutrition, coping and grief. Those are big things. I've had a major injury, so one of the videos I watched, the young lady was talking about she couldn't believe she was never thankful for all that she could do in her life before this happened to her. She said, believe it or not, one of her biggest areas of grief was because she didn't know how good she had it before the injury occurred, because she could walk wherever she wanted. She could run wherever she wanted. So these people are grieving because of that. She said she was grieving for what her life used to be like and that she didn't even appreciate what she had. You need to teach these patients to train for their activities of daily living. They're going to need to be taught how to transfer themselves if they are able to do that and have arm strength, and also how to train their bowels, how to train their bladder. Before they're discharged from the hospital, they're going to need to know how to possibly catheterize themselves, straight cath themselves, to pass urine. They may be incontinent. They may need to learn how to change pads, change diapers, things like that. There is functional electrical stimulation. Your book talks about that to help generate neural activity, to help in the prognosis of some of these patients as far as regaining some of the nerve that's associated with possibly walking, even if they walk later with a limp or with an assistive device. This FES can help them greatly with that. All right, back pain is in the next section of this chapter. Back pain is the most common reason that people miss work. Your book talks about that. And with back pain and ruptured intervertebral disc or slip disc, there's, different reasons why this could happen. But like I said, it is very common, causes a lot of pain. The shock absorbent cushion that are between the vertebrae squeezes out and causes swelling and pain, and that is what's going on with the slip disc. A lot of opioid abuse happens with back injuries also, and this slip disc is diagnosed with an MRI or CT. And your book talks about if the patient is having pain caused sciatica, that bed rest for several days, applying ice packs can sometimes help that and give them a lot of great relief. Also, acupuncture for chronic back pain, acupressure and massage therapy can be helpful. Back strengthening exercises. When you go get your first job, and I know many of you already work in healthcare, but you have already seen these if you do work in healthcare, but they show you videos on protecting your back about not reaching at an awkward angle, not bending over from the waist, but to squat and use your leg muscles. So strengthening the back, strengthening the legs, everybody needs to do that. We don't always have time to do it, but it's important to keep our back healthy and teach your patients about that also. Back strengthening exercises, very important. Surgical procedures, discectomy may need to be performed for removing the disc. Small incisions are used. The patient does have some limitations after they go home after the surgery of things they can and cannot do. They have to keep themselves in alignment. If it's in the cervical area, they may be wearing a cervical collar when they go home. They do not need to sit for a length of time after the surgery. In fact, there's a lot of things that they do and don't need to do, but as far as things they don't need to do, lean over without bending the knees. This is guidelines for a patient with back pain or spinal surgery. Don't lean over without bending the knees. Don't stand or sit for long periods. Don't sleep with their legs out straight without a pillow cushioning under the thighs. Do not bend from the waist to pick up an item. Do not twist from the side to lift things. I've actually known people, different section, but have torn a rotator cuff doing that as well. We do, as far as things to do for patients with low back pain or after spinal surgery, bend their knees, just like I said, to lift an item off of the floor. Do carry items close to the center of your body. But when they go home from the hospital, they're only going to have about a 5-pound weight limit that they're supposed to pick up. Maintain an appropriate body weight. Losing weight, if overweight, helps with back pain, back injuries. Walking and stopping to walk around about every 2 hours if they're on a long trip or an airplane trip as well. And consider how to safely perform a task before starting to do it. That's very important in preventing a back injury as well. I also wanted to mention to go back to chapter 21 and look at pages 480. You've got diagnostic tests for neurological disorders, table 21.6, page 480. It goes all the way over to page 483, but I know that's a lot of reading, but these are important. Particularly pay attention to your lumbar puncture, EEG, CT scan, cerebral angiography, MRI. Make sure you read through the description of the diagnostic test and nursing implications for that. For example, let me give you an example. For an MRI, cannot be used in the presence of metal. That's important. For a CT, may be done with or without contrast. The patient will feel a warm flush and have a metallic taste in their mouth. But as always with dyes, assess for an allergy to iodine or shellfish. So that's very, very important. And before an EEG, we want them to restrict coffee, tea, caffeine, and alcohol before that test. So that's in the nursing implications also. Read through all of those nursing implications. I just touched on some there that are very important. And let me know if you have any questions. Thank you.